eyes that you're covering to. Let's say you take a look at the eye and everything looks totally normal. It looks mildly red. Don't sense anything out of the ordinary, but they are in a lot of pain. So what other things that we had? We had pain out of proportion for the exam. What other diseases? If you're going to make a little separate page of pain out of proportion buzzwords. What else? That's enteric ischemia. We cause that. Yeah. Belly is not tender at all anywhere I touch it. It's just rolling on the stretcher in pain, right? What about, you haven't had it yet, but compartment syndrome can cause some very similar to that, right? Have you had that in clinic yet? Yeah. So compartment syndrome can possibly be similar in its early stages. So in this case, you have to worry about acanthamoeba keratitis, amoeba infection. And later you will find a ring-shaped corneal infiltrate. This person's wearing a contact, usually wears a contact lens. That's right. And there's that corneal ring. So again, do not give steroids without talking to the office. Do not patch and do not use topical anesthetics to acute injury. They do not. What if someone loses a contact lens? They don't know where it went. So, put some numbing pain in there if it's numbing medicine in there. If it's just so much pain and blepharospasm, can't look in the eye. Pull back that eyelid, looking for congenital foreign body. Fluorescein might help, but that's going to ruin the lens. So if it's one of those lenses that they want to keep around, that should be a last resort. There's a medicine you also might want to give to people, not want to give to people who have those permanent contact lenses or those reusable contact lenses. What medicine would that be? Iridium. Why? What's iridium do? What's the fun side effect of iridium? Orange pea and orange tears. It's a fun Halloween trick, and their contact lenses will turn orange from it. You can do irrigation, help loosen the lens, and then once it moves the side of the cornea and the patient will remove it normal. You can try a Morgan lens to wash it out. Don't give up on contact lenses, keep looking for them. However, keep in mind, they may have thought the contact lens got lost in their eye and they just dropped it on the floor and they never caught it. What if someone accidentally screws their eye shut? Whoopsies. So obviously you can't do an eye exam. Don't force the lids open, that's it. There's nothing you can do. Put some antibacterial ointment on it, patch the eye, it might make it a little more comfortable in this case. And then in 1 or 2 days it should open up some. Further, should be more damage. Now the fun stuff. Someone comes in after getting bite, blunt eye trauma, so there might be some congenital hemorrhage. What happened? What was the mechanism of injury that causes blunt eye trauma? Make sure you get a good, complete eye exam, extraocular motions, feel those supraorbital and infraorbital rims as well as its zygoma. And if you're worried about a blowout fracture, test those extraocular motions. Make sure they're intact. If there's any restriction of eye movement or diplopia with an upward gaze, it could indicate an impinged nerve. And check the sensation of the infraorbital nerve as well. If there's a substantial MOI, mechanism of injury, or a suspicion of fracture or an associated traumatic brain injury, get a CT. Tylenol for pain. Why Tylenol? Not ibuprofen or other NSAIDs. Someone got hit in the head really hard, you might be worried about traumatic brain injury. Why might you not do ibuprofen? It's an act as a blood thinner, so it can actually make things worse. Consider intentional trauma, right? Consider possible abuse. Visual loss, severe pain, proptosis, pupil irregularity, new floaters, immediate workup ophthalmology. Raccoon eyes all around the eyes. What could that indicate? They get a basilar skull fracture. There's shading, shadows all around the place. So all those, there's things you always need to rule out with head injuries. I did have a patient come in once after who had been in an altercation, been punched a few times in the eyes. It was so swollen, I couldn't really see inside. They couldn't really assess extraocular motions. That's like maybe just call office, see if I could, just double check on them in the morning. But then like he blew his nose, and I noticed that some of the swelling around his sinuses had like, poofed out. Oh, that's a fracture. That's for sure a blowout fracture. He's blowing. He's actually blowing his nose. He's actually causing eye air to like blow into that cavity. So I sent him to get imaging and told him not to blow his nose anymore. So this is how you make sure you're symmetrically palpating both the supraorbital and infraorbital rims. This is the proper hand placement for it. You imagine looking at this CT. Here's that fracture. See the thinking into the sinuses. I also mentioned Seidel sign. See the oozing out of the viscous fluid, fluorescein, or even without the fluorescein. And here's that very clear loss of extraocular motions. He's not able to look up in this case. Top right. There are all things you have to look out for as well. Right? Nerve impingement as well as possible global rupture. Hyphema can be spontaneous or it might be due to trauma. So hyphema is where there's blood buildup in the eye itself. So you want to, unless you're sure there's global rupture, you want to measure the intraocular pressure. Why do I want to measure intraocular pressure if there's blood building up inside the eye? And why do I not want to do it global rupture? So why would I want to measure intraocular pressure? So what's happening is you're building up the pressure behind the eye with all that extra blood. So that can cause a secondary glaucoma. We need to look for it. Why do I not want to use the tonometer if there might be a global rupture? The tonometer works by blowing air into the eye, measuring the pressure. If there's a global rupture, probably not going to exert more pressure on the eye, right? Evaluate the extent of hyphema. There's a gradation system we use. If the patient has sickle cell, or there's what's called an 8-ball hyphema, where it's completely filled with blood, it's an emergent consultation. And again, with sickle cell, there's a high risk for rebleeding and acute glaucoma. How do you treat it? You want to keep them upright to avoid any staining of the cornea. Fluid analgesia, treat glaucoma if it's available. Again, in this case, this is one of the few exceptions where we do say to do a rigid eye shield to prevent further injury. Elevate the head. So ophtho regarding second. If it's small in a healthy patient, there's no anticoagulation involved. They can go home. Otherwise, if it was admitted, everyone must go to the ophthalmologist within 24 hours. No one can blow their noses or sneeze with their mouth closed. If they have to sneeze, they have to sneeze. Nothing to do about that. But make sure you try to make it as releasing of a sneeze as possible. You can't hold their sneeze. Fill full glass. No aspirin or insects. Here's that 8-ball chemo. In general, microhyphema would be circulating red blood cells, and you have grades 1, 2, 3, and grade 4, which is left. Any questions so far? When you're doing an eyelid laceration, keep in mind there are 5 layers that need to be paid attention to: skin, subcutaneous fat, the muscle, the tarsal plate, and the conjunctiva. If it goes through all 5 of those layers, you must also consider possible global ruptures. If it's less than 1 millimeter at the lid edge, you can just leave it. Otherwise, it's an oculoplastic referral. If it's at the lid margin, less than 68 millimeters from medial acanthus, or the ptosis, or the tarsal plate, or the levator. Any questions on eyes? No one's raising their hand, they just want me to move on from the slide, right? Now, how about any questions about eyes? Moving on to the ears. Okay, so let's say someone was in an explosion or someone was diving, or they had really bad eustachian tube dysfunction and they decided to go on a flight. So there might be barotrauma, there might be a containing membrane perforation. Now listen, if it was an explosion that they were in, and that's what causes barotrauma or that perforation of the TM, also make sure to get a chest x-ray, make sure there's no lung involved. So from diving, there might be like unilateral roaring tinnitus, hearing loss, profound vertigo. By the way, other than barotrauma type of tinnitus, what other tinnitus would be an emergency? In the emergent consultation? Pulsatilus, right? I actually saw one. All right. To keep their head up, you can use anti-vertigo meds to help avoid Valsalva. That's just going to create more pressure. You might need tubes or tympanostomy. If there's a perforation, you can clear any harmful debris using gentle suction. Make sure there's an actual perforation of the membrane, not just an abrasion of the wall. Make sure there's no nystagmus or hearing loss. If it truly is a perforation, maybe put a cotton plug in the area to help keep it dry and protect it. While they're showering, they can use soft wax earplugs. They shouldn't put their head under water. And if it's persistent vertigo, it might have affected the inner ear as well. What you not want to do, don't try to remove a foreign body if there's a perforation, or use suction, or clear out any blood. That might just cause further trauma. As we can ask Professor White to step in, help you out, or another well-trained ENT. If give them some PO analgesics, that's fine. Ofloxacin, if there's contamination, for example, lake water, seawater, they got a tree branch stuck in their ear for some reason, or any other infection, you want to use ofloxacin, an antibiotic with a good early follow-up with the ENT, especially if there's any hearing loss. If it's a penetrating trauma, especially in the posterior superior quadrant where the oscillars might have been affected, and if it's not better after 8 weeks, we might need some surgery. Any questions on someone has too many holes in their ear? Yes.
This is that one slide, but
Sure.
for next diagnosis, maybe I missed it. Why would they get next diagnosis from the TM?
So that could indicate disruption of the islands. Remember, you get stagnant also from benign position vertigo. Benign position vertigo, right? BPPV. It's not necessarily a central nervous issue. Yeah, good question. I believe so. Okay. Cerumen impactions. They come in, they had a stuck up sensation of some pain, itching, decreased hearing, tinnitus, maybe even an odor coming from their ear. Take a look inside. You can't see anything because it's full of wax, which everyone hopefully got a chance to do in lab, right? So there's 3 ways we can remove it. You can use cerumenolytic agents, which will help break down the cerumen. So water, saline, all that's fine. Hydrogen peroxide, oils like mineral or garlic or olive oil, excuse me. Sodium bicarb, acetic acid, which is basically vinegar. And docusate actually can work really well. What's docusate? It's a brand name. It's a stool softener, right? So get some children's Colace and liquid Colace and put it in, and that can help soften it up. Why? That's what Colace does. All those can help. Irrigation does have a 0.1% chance of complication. Make sure that your patient knows about it, and also make sure they know about the percentage. It can cause laceration of the canal, pain, dizziness, perforation, maybe even transient hearing loss, as well as infection of the outer ear, otitis externa, because you abraded the ear canal. And if it looks really red and abraded, you can always give them some prophylactic antibiotics. Or manual removal with one of those ear speculums. So when you're doing the irrigation and the manual removal, it does increase the risk of infection if they're immunosuppressor diabetic. On the other hand, if there's ruptured tubes, you want to avoid cerumenolytic or irrigation. You don't want to put things in where you don't need to. So if it's hard, if it's a TM perforation, you might want to go ahead and send them to ENT. Don't do ear candling. What is ear candling? Yeah, it involves a lit candle near the ear. Why do we not recommend people to light fires near their face?
Get their hair on fire.
They get burned, right? Okay, this is really important. Listen, malignant otitis externa is not cancer. Every year, people get confused. Malignant otitis externa is not an oncological diagnosis. It isn't, it's nasty, it's not good, but it is not cancer. What it is a necrotizing otitis externa. Exquisitely painful otorrhea, more common in the elderly, diabetics, immunocompromised, often pseudomonas. They need an ENT consult as soon as possible, and prolonged treatment with Cipro, either PO or IV. They may also have keratitis, trismus, you have trouble opening your mouth. That could also indicate vascular TMJ involvement because it does spread. Cranial nerve involvement can also cause sepsis. Those are the main things you need to look out for. Right? This is an infection which is spreading fast. It's the necrotizing fasciitis of the ear. Okay, so worry about sepsis. That needs to be very high on your concerns. And then do CT MRI for staging. Keep in mind, trismus is not a complication of malignant otitis externa. It's a sign that there is something wrong. So acute hearing loss. So acute hearing loss is not as scary as acute vision loss, but you need to be aware of what could cause it. And there is a lot of stuff that can cause it. 71% of the time, there's no real vetted answer. Infection could be anything from mumps to syphilis to maybe even strep or meningitis. Might be Meniere's causing this hearing loss. It's some sort of otologic disease. Could be a head injury, some other acoustic trauma, barotrauma. Could be a vascular issue, maybe an hemorrhage. Might be neoplastic. What is the neoplasm we see so often that we talk about back with ears? Vestibular schwannoma, right? Or it might be related to surgery or some other, it might even be related to pregnancy. Get a really good history, including all meds. Make sure you're not taking ototoxic medications. If you're having tinnitus, you might want to ask how often you're taking your aspirin, right? Look in the ears, do a good Weber Renee, so you can see if it's sensory neural versus conductive. Consult ENT if it's sudden, if it's idiopathic, can't figure out what it is, you'll start prednisone for 1 or 2 weeks until they follow up with ENT. Questions on ears. Laceration of the ear, first of all, consider that's trauma to the ear. So check to make sure there's no hemotympanum bleeding behind the tympanic membrane. Make sure there's no mastoid area ecchymosis, which could possibly indicate, what do you call it when there's mastoid ecchymosis? We have raccoon eyes and we have saddle sign, right? That could also indicate a basilar skull fracture. You might even see some cerebral spinal fluid coming out of the ears. Well, that would be indicative of a much more severe head injury, right? So you put a cotton ball in the ear, and then do an auricular nerve block. If it's a superficial lac, you can just go to the 6-0 non-absorbable. If it's through and through, you might require pressure dressing. If there's an avulsion, consult the anterior class, which I'm sure you would do instinctively. So the way you would do an auricular block when you're interested comes up on one of your rotations. I'm not going to test you how to do an auricular block in this class, but hopefully you'll be able to use the slide rotations as well as how to do a pressure dressing. What if there's a foreign body in the ear? Again, that's something we talked about in lab. It might be right afterwards it might come in, or they're coming in with a lot of discharge, pain, bleeding, hearing loss. Discharge is often smelly. If it's a button battery or some sharp edges or tightly wedged against the TM, it's concern for injury. get them to ENT as quickly as possible, especially with a button battery. Otherwise, just a good old fashioned water irrigation. Unless it's like a cotton ball or something, why would certain things not be a good idea? But water, the water irrigation. It's just gonna make it worse. It's gonna absorb it. Like, see, there's a piece of bread or something in here, right? So squirting water in there's not gonna be super helpful. So let's say I take a look and like, oh, there's no way I want to go after that with water. So something I might do is I can use an ear curette, which is we practice with some of those, just sort of try to get behind it and pop it out. Like a bead, that would be super helpful for if you're trying to get earwax out. You can put some, if you're feeling pretty confident in yourself, put some adhesive on the end of a swab, like some derma bond, and go in there. Make sure you dump the derma bonding the swab to the kids. I have a swab sticking over here. Try suction if you have it. Alligator forceps. If there's a battery, it has to be taken out right away. And then there would be irrigation to remove any alkali residue. But if you can't crush the button batteries, you can't irrigate it. And always you can use alligator forceps. If it's a live insect, we talked about this during lab, you might need to use we should use mineral oil or lidocaine first to numb it up so you don't have to fight an insect, which is super good at hiding little places. It's going to be much more painful for the patient. Here's an example of how to irrigate it out. Ideally, you'll be able to just squirt it in water and get behind it and push it forward. I don't know if I said this, but always make sure to use room temperature or a little warmer water. Use cold water, it can cause them to be extremely dizzy. And the final ear emergency we'll deal with is an auricular hematoma, okay, or cauliflower ear. So it can actually cause canal blockage because it can swell up so much. It can happen after a wrestling match or some other trauma. It needs to be drained. You need to drain this hematoma, otherwise it can cause an increased risk of cosmetic. If you see this auricular hematoma, it needs to be drained. Any questions on ears? Nosebleeds. So before you get an H&P, if they're hemorrhaging out, take care of the hemorrhage, then you can get an H&P. Third of the time, if they're hemorrhaging, you might have a coagulation disorder. Honestly, most of the time, by the time you see them, they're done with their nosebleed. Just stop. And then you go in, you say, good job, you did great. Take care. Otherwise, keep the patient upright, maintain compression. Sometimes what people like to do is they will stick tissues up their nose, or they will keep blowing their nose, or they will check every 5 seconds to see if it stopped bleeding. There needs to be constant compression for usually at least 10 to 15 minutes, I would say. You might want to give them a little aspirin to be helpful. They used to recommend cocaine for persistent nosebleeds. We don't do that anymore. Make sure you have a good headlight with a focused beam. And then if they haven't been able to successfully stop it, so have them gently blow up their nose if there aren't any clots, and then you can take a Pledgette, which is basically a nose tampon, and add some lidocaine, phenylephrine, and oxygen on. Pop it in there for about 15 minutes. You can even use some IV transexamic acid. You might need to use a balloon catheter if it's really not stopping. And if you can get it to stop enough that you can go in and cauterize it, go for it, silver nitrate. But you have to do it on a bloodless surface. Once you get it to stop for 15 or 20 minutes, they can go home. Super easy. If it's not getting better after trying everything, then you might need to put some non-absorbable packing in it. So they have to get taken out 2 to 5 days, consult ENT. No bending over, no sneezing with mouth closed, no straining, and no picking your nose. Because that's probably how the children. Number one cause of nosebleeds, especially children, is right. Okay. Only other real emergency other than foreign bodies that we need to take a look at would be septal hematoma. If someone gets smacked in the nose, we need to make sure that there is no hematoma on the septum. It has to be treated because it can cause septal necrosis or an abscess, possibly even cellulitis, meningitis, or a deformity. Needs to be need an IND on it, and then bilateral anterior nasal packing with bacitracin. If there's any constitutional symptoms, it may have already turned into an abscess. And you see an ENT within 24. Okay, so let's say a kid comes in, purulent unilateral nasal discharge, bleeding, maybe a nasal voice or foul breath. Might be something they stuck up their nose a few days ago or weeks ago. It's just now starting to be noticed. So suction can work if you have it, air pressure, ear curettes, again, that's one of the things where if you feel pretty confident about it, you can try glue on a swab. Ear curette can be helpful too, because if you can get around it and push it out, and the mother's kiss, which you may remember from that, can be very effective. But I think especially because this tends to be with pediatrics and tends to be on the younger end of pediatrics, please explain what you're doing ahead of time. Consider will you need sedation for this. Try suction using discharge using some numbing medicine or vasoconstrictor as well. Make sure you're not going to push it further back. The two things which are absolute dangers are button batteries. And if there are magnets, like those earring magnets, on the septum itself, can cause pressure necrosis septum. You can also consider using the balloon catheter technique after good lubrication, and consider ENT consult if you're just not getting it. Question on noses. Who can guess what we're doing? So, again, just moving along with trauma. So there's three types of what's called the Fort fracture. There's blunt facial trauma. The mnemonic you use is speak no evil, see no evil, hear no evil. Right? How far up does the fracture go? Make sure there's no CSF leak, septal hematoma, dental fracture, orbital fracture. You may see loosening of the face, you might see it on CT. If it's unstable or ENT, then you need an ENT or plastics or oral maxillofacial surgeon. Right, nose, I guess. If there's a fracture of the nose, again, what was the mechanism of injury? And sometimes you can see by how the nose is displaced what the mechanism is. And again, make sure there's no associated injuries, the brain, the eyes, the teeth. Palpate it. If you feel crepitus, indication, or irregularity, it would indicate a fracture. It's diagnostic at that stage if you're hearing crepitus. If it's a small isolated fracture of the anterior nasal spine, meaning it hurts only when they smile, they don't really require any real restriction of activities. You cannot see these things on X-ray. It's not going to be helpful, and certainly if it's uncomplicated, it's not needed, unless you're worried about there's being some sort of displacement that you're not able to see on CT for some reason, but usually we only always use CT. Make sure you have good nasal patency, make sure there's no epistaxis, no septal deformities or hematomas. It might look white, it might have purple areas of fluctuance. If it's non-displaced, it's fairly supportive. Copax, keep your head elevated, no contact sports. And then if there is a laceration, you wouldn't use prophylaxis. This is one of the only times you would use prophylaxis. For a laceration. Everyone's good? Stretch. Dental abscesses. So it used to be, when I was first starting off, that a big thing was people coming at dental abscesses looking for some sort of opioids or drug seeking. You don't really need to do that anymore. You can give 600 milligrams of ibuprofen and gram of Tylenol every 8 hours, and that's just as good. They might have some thermal changes, might cause increased pain, percussion can cause increased pain. You can try controlling the pain with dental block, like we learned in lab, or NSAIDs, and that's not going to make the pain go away, but it certainly can reset things for them, give them some relief. This is cellulitis or trismus or systemic involvement of compromise. You don't need antibiotics, but would you use augmentin? If there's a fluctuant abscess, you would do an IV and warm compresses, then it's required. When it comes to trauma, there are 3 things we look for: subluxation, fracture, or avulsions. Okay, subluxation is where the tooth gets knocked out of place, but it's still attached. Fracture is where the tooth itself is broken, and the avulsion is where the tooth is completely knocked out. If it's a primary tooth, if it's a baby tooth, okay, that's it. Nothing else to do. Let's say you can't find the tooth, so you want to do a chest X-ray, right? You want to make sure that you didn't aspirate. If you're concerned for alveolar fractures or mandibular fractures, for example, several teeth, when you're moving the teeth, you have a few teeth moving together. If you move one tooth, 2 or 3 other teeth things would move as well. You have to suspect an alveolar fracture. Count all the teeth. Are they all accounted for? And again, like I said, do that chest X-ray. Primary or permanent teeth, and do they need endocarditis prophylaxis? Let's take a look at the endocarditis lecture. This is your subluxation. There's the extrusive on the left, intrusive on the right. If it's very loose, you might need some antibiotics. But otherwise, if you might go ahead and just put a splint on them and send them up to more. There are some substances you can use to sort of keep it in place until they go see dentist. Just a note of the different areas of the tooth before we get into fracturing. There's the enamel, the dentin, and the pulp itself. And the extent to which the tooth is fractured will affect how you decide to treat. Somebody chipped my tooth. This is a class 1. This is only the enamel, not that much a problem unless it's like super sharp and can end up cutting them. If so, get an emery board and file it down. Painless, doesn't bleed. If they're worried about cosmetics, they can go to dentist. Not a big deal. This is class 2. You take a look, it's actually exposing some of the yellow dentin. It's going to be sensitive to temperature, percussion, forced air, can become infected, might bleed slightly. This one is a type 3. You can see the actual pulp has been exposed. Again, pink, painful, typically bleed. So 2 and 3, they need pain control, they need antibiotics. What if the tooth is just totally knocked out completely? So ideally, what do? Pop it back in. Let's say you're on the scene. Let's say that you thought you were off duty, which never really happened. And someone, like, I don't know, you're watching like kids' soccer game, and some kid's tooth gets knocked out. Then you find it. Pop it back in. Pop it back in. And if it's only partially avulsed, you can just pop it back in, ideally within 15 minutes. Place in protective solution though, if it's not completely partially avulsed, as soon as possible. Let's say again, it got knocked out, right? It's not something you can just pop right back in easily. So you can have them store the tooth under their tongue until they get to a dentist. Keep it in their cheek. Keep it in some cold milk or a saline solution. If it's a child's tooth, again, not a primary, because a primary tooth just let it go, but it's a child's secondary tooth. But you still don't want them because they're like 6 years old, 8, 7 years old. You don't want them holding a tooth in their mouth until they get to the dentist because that's going to disappear at some point. You can put it in the parent's mouth. And it's between 6 and 10, and we think it's going to be.
I feel like I don't want you that much, no.
Let's say you don't go to the dentist until 2 hours later. So that periodontal ligament, which is an important part of the tooth, it's dead. It's not going to regrow as easily as it does. The whole tooth's now to just be washed up. It's no longer an organic tooth. Okay, if that would happen, you'd actually have to soak it in some Clorox and citric acid and some doxycycline. You put it in, and it sort of eventually becomes part of the jaw again, like an implant. So I talked again, like you're at the soccer game, you're in the field, whatever it is, and the tooth falls out, you find it under the bleachers. So it's contaminated. But because the periodontal ligament is so important to helping it regrow, we don't want to like give this a vigorous wash. Okay, you only hold it by the ground, and maybe you irrigate it gently with normal saline. So you get to the office, mount them up, irrigate the socket, you suction, and then you read. So important part of this is just to remember that the teeth can be reinserted, and they have to be in a protective solution before they hurt. You're going to eat doxy for 7 days, soft diet, until it grows back in, tetanus vaccine. Splint it if necessary. If like, you really think your dentist needs to take a look at it eventually. So how do you splint it? So we're gonna ask. So there is a type of paste that some places have that you can put on it to help it stay in place. And ideally, had we been able to get the dental people on board, I would like to be able to teach you guys how to suture a splint. Don't worry, you didn't miss out because we've never done it. That's something else we're trying to like put in, but you can use sutures to sort of tie the tooth down. The idea is just that you don't want it tight enough that it's going to have tooth that's going to have. We're in the home stretch. So some people have either because of TMJ or just the way they're born, they can dislocate their jaw fairly easily. Might be after a yawn or a large bite, laughing, or traumatic jaw injury or some sort of sign drug reaction. They can't close the jaw. It might actually look like it's protruding forward. If there's no trauma involved, then we can just try to reduce it. If there is a possible trauma, get an x-ray to make sure there's nothing broken. There's two reduction techniques you can use. You can try gag reflex, which all of you practiced this summer. There's gag reflex going, and that helps the animal come down and contact in place. Another option would be to use a syringe where you actually put a syringe in their mouth and rotate it back and forth between the back teeth. Draw back in place. Otherwise, you have to just do a manual reduction or the wrist pivot method, soft food diet. So this would be a manual reduction on the left, and here's the wrist pivot method. Basically, just trying to maneuver. French mouth is usually not an infection. It's usually not an infection. It might cause pain, fever, foul breath, or metallic taste in the mouth. There might be some red swelling of the overlying grayish pseudomembrane. Might be lymphadenopathy. But often, all you need is warm saline or hexamine and a dental referral. NSAIDs may actually help them. If there are systemic symptoms like that fever, you may use it. So let's say someone just got a tonsillectomy and now they are bleeding profusely from their throat. Bleeding from the surgery complication. So this is an emergency because it can block the airway. May even cause hemorrhagic shock. Usually happens between days 5 and 10. They need to be NPO. You can put a tonsillar pack. It's moistened with thrombo, lido, and epi. You can even put a suture through the pack and tape the suture to the face. Right, so you're not suturing the tonsil in. What you're doing is you're putting a suture through the pack and then taping it to the face. Why are you doing that? You don't want them swallowing the pack. But yeah, so that way it's like sort of like taped to the face. And you might need some nebulized epinephrine. When else would we use nebulized epinephrine? Or racemic epi? The group. You know, these. Okay, finally, someone swallows a foreign body. So what was swallowed? So if there's anterior neck tenderness, masses, some sort of subcutaneous emphysema, you want to make sure it's not in the chest. Check the hypopharynx when you tuck your press or a head lamp mirror. If you can see what it is, you can use a curved forceps to take it out. If the symptoms are mild, meaning there's no sign of any blockage, and you can't visualize it, as long as they're swallowing okay, liquids and solids, then they really are good to go. Someone, let's say, feels that they swallowed, and they had someone, so I took teenage kid took too big a bite of chicken, but it's stuck in his throat. So I had them take a swallow, and they weren't able to drink water, which was bad. So clearly a blockage. So who do you call at 3 o'clock in the morning in emergency room? Do you call ENT or do you call GI? So the answer is it's always the second person you call. Because you call ENT at 3 in the morning, they say you need to call GI. Call GI, they say you need to call. So maybe you'll get someone who'll be nice enough to come down, but usually they'll just shove it on someone else, meaning both of them can indicate. If it's in the, I mean, we already saw how to tell from the chest x-rays, but if it's in the tracheobronchial tree, you might see coughing, wheezing. Esophagus will probably be more true. You need to be careful with fish bones. Why? Because they can actually perforate the esophagus within the next few days. So even if you can't see it, they need to be seen soon. Chicken bones will be a greater risk of any serious injuries. Neck abscesses might even cause an esophageal carotid artery fistula, or mediastinitis. So if it is a bone, at least get a good x-ray so you'll be able to see it a little easier. Sometimes it might just be a bit of an aspiration of the esophagus, and that's what they're feeling. But even then, it needs to be a pretty good close one. So essentially, if they're not swallowing liquids or solids, it becomes pretty much immediately seen immediately. If they are, if you can get an x-ray and see that there's a bone stuck in there, again, pretty immediate. If you're really not picking anything up on x-ray, and they seem pretty healthy, you could probably have them discharged with pretty strange. Any questions? Yeah, it was a fun lecture. Sorry about the break in the middle.